we have been saying that purines A and G, when metabolized in humans, they will give an end product which is uric acid. At the end, we can't further metabolize it because we don't have the enzyme uricase, so it's excreted in this form. But other species are uricase positive, and they further metabolize uric acid into allantoin, which is more soluble. Why I'm talking about that? It's because there is a therapeutic class called uricase. In medications, we use uricases as a therapeutic class to catabolize uric acid in gouty patients. Now we're going to talk about crystal formation. Finally, let's assume that we already have a hyperuricemic state. Hyperuricemia, crystal formation. Now, we have Mr. Uric acid here. In normal conditions, its level is normal and normal pH 7.4. What happens? Uric acid is an acid. In this pH, it is going to lose a proton, so it's going to be negative. When uric acid loses a proton, he will going to bind a sodium ion. He loses a proton, becomes negative, and binds a sodium ion. Okay, I'm going to show it this way with an S. This is Mr. Uric acid that has lost a proton and bound a sodium ion. This is called MSU, monosodium urate. This is in the normal condition. So, in the normal condition, we have MSU in the circulation. Now, on the other hand, if we are always in physiologic conditions, but uric acid levels are up, increased, hyperuricemia. Now, when we have hyperuricemia, we are going to have a lot of MSU molecules. A lot of MSU molecules are going to have a party within our extracellular compartment and join hands. When they join hands, they are going to be crystallized and make needle-shaped crystals. These needle-shaped crystals are going to be deposited within the joint cause inflammation and give the clinical manifestation of gout. It sounds like I am repeating what I have been saying in the beginning. It's not the case. I'm going to tell you now why it is not the case. So I'm going to clean the normal part here. Increased. I guess I said it in the beginning. Hyperuricemia does not always lead to inflammation. In hyperuricemic patients, only a small proportion of these patients will develop gout, will form crystals and achieve the inflammatory response here. The transition from hyperuricemia to crystal formation is not systematic. There must be some factors that make these excessive MSU molecules to form crystals. It is not a systematic transition from hyperuricemia to crystals. We must have some factors. Also, a deposited, here I'm going to draw a panel here, which means that it is not a systematic transition from hyperuricemia to crystal formation. And also here, after deposition, we can have deposited crystal here within the synovium, within the cartilage, but no inflammatory response. And it is proved in patients with asymptomatic hyperuricemia, they have some uric acid deposited, but there is no evidence of inflammation, no clinical manifestations. This is an important point to highlight here. Hyperuricemia, crystal formation, deposition, and inflammation. From hyperuricemia to crystal formation, it's not systematic. It's not always. Only a small proportion of patients will make crystals and will have actual gout. Why I'm saying that? If somehow you face a patient asymptomatic, but you look to the uric acid and you find it elevated, don't treat, because only a small proportion is going to develop gout. Now, what are these factors, these environmental factors that influence the transition from hyperuricemia to crystal formation? There are two important factors that we are going to discuss: low temperature, low pH, which means acidic environment, and there is also the salt content and vibration. Now, in low temperature, there will be a decreased solubility of uric acid. Now, if I tell you that the more frequent localization of gouty arthritis, gouty flares, is the MTP joint of the big toe, metatarsophalangeal joint of the big toe. This site has low perfusion because It's situated in the farthest point of the circulation, and it has a high surface to volume, a high surface to blood volume ratio or relationship. Low perfusion, low heat delivery, bigger surface related to the volume of blood that it receives, high heat loss. Decreased heat delivery, increased heat loss, so we are in low temperature state, which makes this localization more susceptible to gouty arthritis. It is said that in the initial presentation, 50% of patients present with an MTP gouty arthritis, whereas in the whole gouty patients, at some time of the disease course, they will develop an MTP gouty arthritis. 90 of them will have an involvement of MTP. So this low temperature concept can explain why the MTP. We haven't started talking about clinical presentation, but you already know that the MTP is involved. Is the most site that is involved. Also, later we're going to see that gouty flares are self-limited. Here we can incriminate the temperature too. Why? Inflammation, high temperature, inflammation and heat. Uric acid becomes more soluble, and the problem is resolved. So we have discussed now low temperature and MTP localization. MTP low perfusion, it is far away from circulation. Low perfusion, low heat delivery. It is we have a large surface relatively to the volume of blood that it gets, so big loss of heat, low temperature, more susceptible. Now we know why, the MTP. And self-limited flares. The pH now. Low pH and acidic environment. Acidic conditions like exercises, respiratory insufficiency, alcohol consumption, they are related with gouty flares. They are triggers to gouty flares. This acidosis can explain why they are triggers. An important point also here, gouty flares, I said earlier, it's good to always ask two questions, where and when. Here in gouty flares, where? We said the MTP. When? I'm going to tell you now. At night. Why at night? Yes, someone would say it's an inflammatory disease, an inflammatory joint pain is going to occur at night, etc., etc. But there is another point incriminated here in night time. At night, when someone is sleeping, we have a slightly decreased respiratory rate, which means a mild acidosis, which can be incriminated to in this nighting time. This information about low temperature and low pH, there were in vitro experiences that have proven that these factors are incriminated in crystal formation, and also epidemiological studies have shown that the NTP is almost always incriminated, nighttime also. So you can see now where does it come from. Okay, so hyperuricemia, crystal formation, if there is promoting environmental factors that will help the initiation of crystal formation,